Okay, so thank you again for being here. I'm going to start sharing my screen. All right, so the first thing I'm going to do is, this is my introduction, and now I'm going to talk to you about the goals for the program today. So by the end of the day, I want everybody listening to be able to identify most common issues that elderly people experience related to their urinary tract system. I want each of you to become familiar with useful interventions. If you do encounter a problem, what do you do about it? I want you all to become familiar also with medical terminology and just common medications that you might see in the community that are related to the urinary tract. And also I want each of you to be able to identify when an issue goes from just being like an irritation for an older person to an actual medical problem to a medical emergency. Next, this is like an overview of what each of these slides are going to be. We're going to do a case study, a discussion about a kind of a make-believe case. We're going to go through anatomy, just basic anatomy, review the urinary tract system. We're going to talk about urinary tract infections, urinary incontinence, and urinary retention. These are kind of some big three things that anybody can experience, and there are medical issues that affect everybody, but very specifically to older adults, and we'll talk about what makes them special to older adults as well. We're going to talk about useful tools, what you can do, anybody in the community, not just medical providers, and when something becomes an emergency, and then also the frequent medications. Then we're going to wrap everything back to that case study at the beginning, and then we're going to kind of talk about what we learned. So I'm just going to pause here before I go any further, and Ashley is going to read out questions that are posed in the Q&A. So I have these questions written down. It says, how do these problems affect your clients? How do these problems affect your ability to care for clients? And what do you integrate into your practice to improve this? If you see it, what have you done about it? Do you have any kind of thoughts about this? So Ashley, just a couple, if there's anything that is being put in the Q&A, then this would be a good time for us to talk about it. And if not, that's okay too. We can just kind of move on because I'll ask you some more questions in a second too. But I just want this to be interactive and thoughtful and engaging for people as well, even if it's just Q&A.
Yeah, absolutely. As of yeah, okay. I forgot to mention this. Someone is reminding me of what I've forgotten. So the slides will be available after the presentation. So that's the only question in the Q&A. Are you wanting people to respond in the chat to the questions that you're asking right now? Because I can monitor that and share that with you.
Yeah, if that's being put there, then that would be great. This was an opportunity for people to talk if they want to, but I'm not going to pause this talk very long because it's kind of long. So if there's no questions in the chat, then that's okay too.
Yeah, I'd say no questions on this end.
Okay, sounds good. Thank you, Ashley. All right, I'm moving on to the case study. So this is a case that I actually made up, but this is not really that uncommon. This client and clients like it probably exist in the community, and you've probably met people like them. So this is James. He's an 82-year-old male. He's living in the community alone. He cares for himself in his home, but he requires case management services. He requires it for coordination of care, in-home support to do independent activities of living, including things like cooking. But he also suffers from arthritis, and it causes severe hip pain. In addition to his arthritis, he also has what's known as benign prostatic hyperplasia, and he reports that he has difficulty urinating. He has accidents sometimes where he dribbles urine, and he does wear Depends for this, but he says it's hard for him to change his Depends because his knees and his hips hurt. So often, as well as not wanting to go through the pain of changing, Depends are expensive, he says. So he doesn't change them very often, about once a day, despite being incontinent throughout most of the day. So lastly, in order to minimize the number of times he has accidents, he says that he reduces the amount of water he drinks because he doesn't want to have accidents as often. So if there are any concerns that you had listening to me talk about James, if you have any possible interventions and ideas that you would want to start talking about with James, then write it in the chat now. It would be a good opportunity, and then we can talk about it. My goal here is for Ashley, interrupt me at any point. My goal here is for each person to listen to that and start thinking about things that they've seen, and then we're going to go through a whole talk, and then you might have different thoughts about this afterwards.
All right, looks like we are getting some people coming into the chat. I'm going to, all right, looks like we've got some folks in the world. There's a lot of pretty solid clinical language. So I'll give people a minute or so to kind of filter through. So we got one person that has 3 primary concerns, and they've listed one of the 3. So I'll wait till they get all 3 in before I share them. We've got one, Kate Blank is saying major concerns are dehydration and infection. And then Cesar Quadra says concerns are dehydration and infection. And okay, so the 3 primary concerns from Monique Hamilton, we are waiting on number 3, but I guess I will list 1 and 2. So of the 3 primary concerns, 1 seems like there's a question, which is what is the recommended treatment for benign prostatic hyperplasia? And then 2 is dehydration. 3 we are still waiting on. We have more in the chat. So Wendy says high risk for UTI, possible interventions or finding support system or care providers to assist with ADLs. And let's see. Still waiting on number 3. Okay, someone else is saying, emphasize the importance of drinking water, find different type of depends, like options, and beware using a urinal if not cleaned regularly regarding infection and a UTI that could become septic. Then we have even more. So, okay, wow, no, we got fast and furious feedback. Okay.
This is awesome.
All right.
It's exciting for me, actually.
Yeah, this is good. Okay. So we have, in addition to those previously mentioned, knee pain is also an issue. Someone else listed falls. Could you use a smaller pad instead of a full depends? Of course, this needs a medical eval, but there are less troublesome products to wear. Additionally, we've got people talking about treatment for hip and knee issues, questions about can the pain be managed more effectively, and a caregiver assistance might be needed. And then additional kind of intervention ideas. So what DME does he have access to or needs, and can insurance cover the cost of incontinence supplies? Other folks have said poor pain control, infection, dehydration, skin breakdown, increased isolation, and poor hygiene. Okay, we've got number 3 is infection also, but that was stated already. Yeah, okay.
Cool.
Should we be keeping a list of all of these or?
No, this is great. Okay, this is awesome. I'll stop you there. This is,
okay.
I think that number 1, I was thinking that, I mean, I knew everyone was going to have really good answers to this, but you guys are kind of like getting to my whole talk. So everyone is nailing it on the head, and a lot of people are even thinking about things I didn't even think of. Which one of them, whoever said the thing about wearing like less cumbersome pads, yeah, like there are female pads that you can put on a pair of underwear that can be helpful if somebody's just dribbling. So that's a really good point, and something I didn't bring up in this talk. So, but I'm going to mention a lot of these things too. So thank you. I'm actually not going to go through all of them. The point of that was I wanted everyone to start thinking, and then at the end we're going to talk about this again, and I was hoping that we would get new and different ideas, but actually basically everyone's incredible, so maybe we won't have that much different.
Another thing someone mentioned was general anxiety, right? Like the psychiatric kind of
absolutely
of being in this situation, and how to manage like the distress around these situations.
Yes, and we're going to talk about that too. That's awesome. Okay, thank you everyone for your participation. That's really exciting. I feel energized by that. So next, we're going to talk about medical terminology. I'm just going to go through this really quickly because it's not super exciting or interesting, but it's very important to go on with the rest of the talk to know these things. So first thing, genitourinary system. That is the organs of the reproductive system and the urinary tract system, like the GU system is what we call it in medicine. And that is both of those systems combined. They combine them mostly because they are so close to one another and they work together in some ways, especially for men. So the next thing is kidneys. Kidneys are these bean-shaped organs. They're about like the size of your fist. That's why I'm making a fist. And they sit on either side of your spine, like in your back. And these things filter your blood. The byproduct of the filtering of the blood is urine. So the kidneys make urine. The urine then drains down the ureters. Those are two tubes that sit next to, that sit below the kidneys. They connect to the kidneys and they plug into the bladder. And then the prostate is about the size of a walnut, and it is a gland, and it creates seminal vesicle fluid, the fluid that protects like sperm. So this is often enlarged in older men. There's a statistic that says it's like over the age of 65, it's like 80% of guys have some level of enlarged prostate. It is pervasive in the community. The next thing is the urethra. That is the tube that empties urine from the bladder. And then the urethral meatus is the actual opening to the outside of the body. And then I added benign prostatic hyperplasia there. That is the enlargement of the prostate. This does not necessarily mean it's prostate cancer. That's a misconception in the community too sometimes. But I added that on there because it is so incredibly common. So this is just a picture of GU anatomy, kind of 101. Take a look at that. That goes in the kidneys, the ureters, the bladder, prostate, urethra, all the things we just talked about. On the top is the adrenal glands. I'm going to kind of skip over those, but those are important in like endocrine. They create important things like cortisol and other. They control blood pressure and all kinds of important things, but they're not necessarily super connected to the GU system, but they're physically connected to the kidneys. Okay, so now that we have some basic anatomy review, let's talk about the anatomy that's specific to older people. Number one, muscle weakness, generalized muscle weakness. This doesn't only go for the GU system, this goes for the entire body for older people often, but the bladder is covered in all these muscles and nerves that are very important in squeezing to make the bladder be able to empty and, you know, for you to be able to urinate. So if somebody has decreased muscle tone, decreased muscle weakness, then there might be issues with emptying somebody's bladder. There is also elastin throughout the body. Elastin starts to lose its elasticity over time with older adults. That goes for skin, that goes for all the organs in the body. I mean, anything that is made up of elastin, but the bladder is a specifically highly elastic organ. It expands, it contracts. So it really relies on that elastin. So because elastin decreases for older people, then their bladders cannot expand like they should or used to when they were younger. And this makes a less stretchy bladder results in somebody not being able to hold their pee as long or their urine as long, sorry, I should say. And it makes it so they have to use the bathroom more often.
Becca, quick thing from the chat. There's one request just to slow down a little bit. Someone's trying to take notes.
Oh, sorry.
I think it's okay. Catlin has already mentioned that we will be sending the slide deck to everybody. There's also another question on what is the meatus, if you could just go over that again.
Yes, the meatus, you have, if you look at the picture that's sitting here, there is the urethra. That's where the urine drains from the bladder. The meatus is the actual hole, the opening to the outside. So if you are doing an exam on somebody or just knowing anatomy in general, this is the thing that you actually can see from the outside. It's the urethral meatus. Meatus in medicine and anatomy actually just means like orifice, opening, that type of thing. So the point is you can't see the urethra, but you can see the urethral meatus from the outside. I talk fast. I'm sorry. I will go slower.
No, I think you're good.
Okay. Okay. So
also, just for everybody who's attempting to take notes, the slides will be available. This is currently being recorded and will be put up on the IOA YouTube in the next couple weeks.
Thanks, Ashley.
No problem.
Okay. So the next thing I'm going to touch on is, so we know that urinary tract infections are common in older adults, and we're going to talk about that in a second. But bacterial colonization is something that's very specific to older adults, and this has to do with anatomy. I'm going to touch on this really briefly, but the point is that I really want people to take away, that I'm not going to get into detail in this talk, is that simple existence of bacteria in the urine does not always mean a urinary tract infection, especially for older adults. There's a lot of, there's something called microbiome like stewardship or antibiotic stewardship in medicine, where you have to be really specific and careful about when you give antibiotics, because otherwise, if you're not careful about it, people can develop resistance to antibiotics, the bacteria that exists can, and then you run out of options to be able to use antibiotics. And then, at the end of somebody's life, they've built up bacterial resistance to all kinds of things, and they have very few options for antibiotics. So I'm not going to get into exactly when something becomes a urinary tract infection and how much bacteria has to exist and all these things, because this is really kind of specific to urology. But I just want you to know that this is a phenomenon that medicine is being very careful about. And bacterial colonization is very specific to older people. Lots of young people don't necessarily have that. Okay, so, and then I want to just talk about kind of like the difference in the anatomy of men and women, and how those things can change your risk of issues. And that is, number one, women have decreased estrogen as they get older. And this can change the bacteria, the good bacteria that exists in the vagina. And if that's all changed as a result of estrogen, then that can result in infections that can invade into the urinary tract system. So because of decreased estrogen, women are at high risk of UTIs. That's the first thing. And then also for men, prostate changes. The enlarged prostate is a giant risk factor for UTIs and urinary incontinence and urinary retention. And we're going to talk about that soon. But the existence of a prostate and an enlarged prostate is a risk factor. And it's something that's specific to men that is not to women. All right. Now I'm just going to define those things in case I'm kind of I may have put the cart before the horse. I think that's the expression, because I just talked a lot about incontinence, retention, urinary tract infections without defining them. So this is my opportunity to do that. Urinary tract infections is the infection of the bladder, the kidneys, or the urethra. And this is at any point there's an infection in the urinary tract, then it's a urinary tract infection. It becomes most serious if there's an infection in the kidneys. Incontinence is the inability to control your bladder, resulting in leaking of urine. Urinary retention is when there's somebody that has difficulty urinating and they cannot fully empty their bladder. And now let's talk about each of these things. Urinary tract infections, signs and symptoms, common signs and symptoms. The typical things that people think of is painful urination, frequency, feeling like you have to void the second that you or urinate the second that you feel like the urge to, and then, or frequency is where you have to go often, and then urgency is where you feel like you can't hold it. All of those things are signs, but there's one that's very specific to older people, and that is mental status changes, delirium, confusion. This is well known in the medical community to be sometimes the only sign that an older person has an infection, and specifically to UTIs. So I think Anne in the clinical collaborative told me a story about somebody that was living in the community that got hospitalized to a psychiatric hospital, an older person, and they were there for a period of time before anybody found out. In fact, it was a urinary tract infection the entire time. So this is not as well known as maybe a lot of people in the medical community think. So it's something I want to make sure that we talk about today. Okay, next, women versus men. Women, maybe a lot of people know this and maybe some don't, but women are much higher risk of getting urinary tract infections. And the reason is actually quite simple. It's because the thought is that your infection is introduced through the opening through the lowest route, and it goes up the urinary tract all the way up into the kidneys if it's not treated. And for women, our urethra, females, the urethra is 4 centimeters long, and for men, it's over 20. So you can see why infection, bacteria has much less ground to cover for females, for it to become something more serious. And then I have a little statistic here. 10% of women over the age of 65 will experience a urinary tract infection within a year. And then 0.05% of men will have a urinary tract infection in a year. So much more common for women. Okay, so what causes it? Incomplete emptying of the bladder. Our body's #1 defense system for getting rid of bacteria that's introduced is urinating. So that's the first thing. If somebody has difficulty urinating, is not urinating often enough, or they're dehydrated and that results in not urinating enough, then they're at high risk for UTIs. Another thing is constipation. And I don't know about people that are working in the community, but in my time in gerontology, I've known that constipation is very common in older adults. So it is, the thought is in medicine that if somebody's bowels are very full of stool, it can expand, and then it's very close to the simple proximity of being close to the bladder can then result in cross-contamination of those two systems. So then dehydration, like I talked about, you're not urinating as often, your urine is more concentrated, risk of UTI. And then habits, just things that people do that are not good for risking the risk for UTIs, which is, we tell people to wear cotton underwear, keep the area very dry, keep the area clean. And then wiping front to back is something we tell people as well as women, because we don't want cross-contamination of those two systems as well. Voiding frequently, avoiding caffeine, avoiding alcohol, both of those are dehydrating. Even though they're diuretics, so they kind of make you void often, but then they actually result in dehydration, despite what you think if you drink a lot of coffee. So what do we do? What's the treatment? The treatment is aggressive hydration, confirming that's in fact a urinary tract infection that needs to be done by a doctor, and treatment with antibiotics once that's done. So we also have very specific medications that can relieve pain and stuff like that, because there's a lot of symptoms related to it as well. And then interestingly, like I talked about, the anatomy changes with estrogen for women, it is well documented that if women that are over the age of 65 are given estrogen creams and replacement, then they have a reduced risk of UTIs as a result. Next, urinary incontinence. So I'm going to really quickly go over the different types of urinary incontinence. And the only reason is it's not necessary for people to really fully know the difference, but in medicine, they really focus on the difference because the different types of incontinence that people experience changes the course and the treatment entirely. So the first one is stress incontinence. This is when somebody leaks urine in a high stress situation on the body, like jumping on a trampoline, laughing, or vigorous exercise. That puts pressure on the bladder, and if somebody can't hold their urine, that's what stress incontinence is. Urge incontinence is if you feel like you have to urinate and then you cannot make it to the bathroom in time. That is urge incontinence. Overflow incontinence is a phenomenon where in fact somebody thinks that they're emptying their entire bladder because they're having accidents constantly, but in fact what's going on is their bladder is always full and your body is getting rid of the urine that it can, because you have it's where your bladder's full all the time and your body's getting rid of some of the urine, but it's confusing because somebody's having accidents, so you wouldn't think they're full of urine. Okay, last one, functional incontinence. This is really important, and this is important because it's a new, kind of like a newly developed definition made by geriatrics. Functional incontinence is for older people that are functionally, that have functional deficiencies or disabilities, I should say, that make it so it's hard to get up and go to the bathroom. If somebody's sitting in a wheelchair, or it takes them a really long time to get to the bathroom because they have a walker and they can't make it simply because of their functional ability to get there, that is called functional incontinence. So what are the causes? Number one is muscle weakness. Why does somebody get muscle weakness? Well, it can happen for a lot of reasons, but one that I really want to focus on is nerve damage. There are tiny nerves that connect to the muscles that help the muscles squeeze. And one way that nerves get damaged over time is diabetes. That's a big risk factor. And then another thing is just general nervous issues, like neurologic issues, I should say. So spinal cord injuries or Parkinson's disease. Those are things that are actually issues with the nerves themselves and not like damage to the nerves from another existing condition like diabetes. So those are also situations where people have incontinence as well. So, the reason I wanted to talk about the different types and different ways that people have incontinence, because when a doctor asks for a urine diary or like avoiding diary, they'll tell you, write down how often you're urinating, measure how much you're urinating. That's why they're trying to get to the bottom of exactly what's going on. So it seems like a silly thing to keep a diary of urine, but it's important. But the next thing is, and the last thing is, I want to just talk about something associated with urinary incontinence is incontinence-associated dermatitis. That's infection or inflammation, I should say, of the skin related to urine. So you have to think about urine as being this kind of high pH, very acidic substance. It has enzymes in it that break down skin. That combined with just being wet all the time can also break down skin. So if somebody's incontinent and they're sitting in a wet Depends, they're at very high risk of wounds. Think about when, dentists tell you not to eat really highly acidic foods like lemons and things because it breaks down the enamel of your teeth. It's the same thing with skin and urine. So that's something I want people to be aware of in the community, is if somebody's incontinent, they're at very high risk of wounds. So the last thing is treatment. What do we do about it? So the way to diagnose the different types of urinary incontinence and what the actual issue is something called urodynamics. That happens in a urology office. It's kind of specific to urologists. Not even primary care doctors do that. But they might end up doing things like certain exercises, trying to get you to do pelvic floor exercises. Pelvic floor meaning all the muscles that squeeze around the bladder. They can help you strengthen that with certain exercises. They can inject Botox into the bladder. They can do nerve stimulators, which is a surgery. They can give you medications. And we'll talk about some of those medications at the end too. And then timed voids is also something that they have you do, like void diaries.
Becca, I have a question.
Yes.
Well, I know. I have a question that's popped up in the chat.
Yes.
Edward, I guess I'm sorry. I suppose a question from the audience is, my wife doesn't seem to know that she is voiding both urine and feces. How is this possible?
Yeah, well, I think that if it's both urine and feces, then there's likely, I can't answer that necessarily, with the exception of I don't know all the details of this person's condition, but it could be muscle weakness. It could be something like nerve damage, and to really get a diagnosis on that would mean to talk to a urologist. And the fact that there's also incontinence of stool, that's a separate issue as well. Sounds like they can be connected, certainly, because if it is related to muscle weakness, then those can be connected together. But nobody can really make that diagnosis or assumption without doing the proper testing. And that urodynamics I talked about can do that. It can test to see okay, if somebody's having an accident, are the muscles squeezing appropriately? So they can do that with urodynamics. So I can't answer the question, but a doctor certainly can.
Awesome. Yeah, it looks like dementia is also in the picture.
Dementia is major. Yeah. Dementia makes it so those nerves can't necessarily talk to, your nerves are all connected to your brain, and those nerves go down to every part of your body, and they connect also to the bladder and to the pelvic floor, that really important group of muscles that does a lot for us. And if things aren't being communicated through those nerves, then it can result in incontinence in a couple of different ways.
Awesome. Thank you.
Okay. Okay, so next I'm going to talk about retention. Urinary retention. What are the causes? Obstruction is the first thing. And when I say obstruction, I mean there's a physical obstruction, like a block in the road. Something is stopping the exit of the urine. And in women, this is super, super rare, very common in men. And you might be guessing it's probably because of benign prostatic hyperplasia, BPH. But for women, it is rare, but it does happen. And something that I wanted to add to this talk was for women, there's a condition that's really not uncommon for older women, especially women that have had children and have had weakened pelvic floors, is vaginal prolapse. That does occur. And I added a picture to this slide to give you an idea of what happens. And if there is a prolapsed vagina, it can push on the ureter, which is the tube that empties the urine out of the body. And if that's blocked, then you can have urinary retention. So that's one way that a woman can have urinary retention, although there's other things, and I'll talk about those in a sec. But that's the physical blockage that I'm talking about. For men, the most common physical blockage is the prostate. And then there's also muscle tone and weakness. Like I talked about, the nerve damage, nerves not communicating. That can be, I added diabetes as the most common thing because I'm thinking like, what are things that are happening to people in the community? And then also something that can cause urinary retention. It doesn't always, but you have to look at somebody's medications. Is there a medication that has high risk of urinary retention associated with it? And the answer is a lot of people are on these medications. Anything that suppresses, we call these in medicine, central nervous system suppressants, something that kind of makes everything in the nervous system kind of slower. Those medications include medications for seizures. It includes narcotics like oxycodone. If somebody has urinary retention or issues with urinary tract infections, because remember, you're sitting in the bladder too long, high risk of infection, then looking at people's medications could be helpful. Again, this is something that a doctor might do, but if anybody is in the community is looking at medications, it's something to think about and just to ask your doctor about. And then I just added lifestyle there, because if somebody has also is taking medications like that and has a very sedentary lifestyle, that could be a risk of urinary retention as well, especially in men. So what are the complications that result in urinary retention? Why do we care? The answer is infection. And then not only that, but if somebody has the bladder full of urine that's very concentrated for long periods of time, kidney stones develop from the chemistry of the urine, as a lot of you know. But if urine is sitting in the bladder too long, you can actually get bladder stones too. And the only way to get rid of those is surgery. So that is why we care. And then also I'll talk about this later when things become more emergent, but things can backflow into the kidneys and there can be kidney damage. Okay, so next, treatment. What do we do about urinary retention? How do we treat it? How do we diagnose it? Urodynamics. That's where they're looking at the bladder squeezing, that type of thing. That's what a urologist does. That's how they diagnose exactly what's going on. And then treatment, remove the blockage. For women, that might be a sling is placed, that's surgery for the vaginal prolapse. For men, it might be they reduce the size of the prostate with surgery, or you can take medications for enlarged prostates, and we'll talk about that later too. For older people, obviously, surgery is not a great option for a lot of older people. Medications are much better. And then lastly, if they can't fix the problem with some of these other interventions, there's a lot of other ones that I'm not mentioning here, but self-catheterization is the ultimate hard stop. And that is, if you can't get the urine out naturally or by any other means, then you have to physically get it out with a catheter. So some people might be familiar with
Becca, before
patients that
we
have had to do
turn
that.
to the next slide,
Yes.
we have, I think this kind of speaks to your, kind of like all the causes. So I've got a question in the Q&A. It says, how do you deal with facilities diapering residents, not due to incontinence and dementia, but ease of care or labor, because residents require 2 workers to bring to the toilet? So these aren't dementia residents, but they're fully aware of diapering, but are embarrassed and not being changed regularly. Kind of a complex question, but felt like appropriate to bring now.
Yeah, definitely. That I think that you're speaking to something that's really important here, which is all of the barriers that exist to this stuff. Like I'm having this whole talk about, oh, this risk factor causes this, but in reality, what's happening? And the truth is, things like that, people are not getting what they need. And I mean, it's kind of a shame. It's like to say that it's at the for the ease of people taking care of clients and patients, but practically, how easy is it for somebody to be able to get up and go to the bathroom as often as they really need to? And I hope the answer is everybody can get up and go to the bathroom when they need to, and everybody has the help that they need to get up and go to the bathroom, and not to have a depends placed just for sheer
But
ease. Or
yeah. I think maybe this just taught me something, because now I think, because we know obstruction muscle tone medications lifestyle, we know that these things cause problems and can cause more things to be more like, can make people more at risk of infection, or kind of increasing risk of infection. Now, I think now that we know that these are risk factors, this is an advocacy opportunity, right? Like if we see that we're seeing depends, someone's like, educate the community and then advocate for loved ones. Yeah. So I think now, I guess in this situation, right, if we're seeing someone putting diapers on residents when we know that they should be taken to the toilet because it's, I think, better for their urinary system, would this be an opportunity to advocate for people to be actually taken to the bathroom more often, like physically?
Absolutely.
versus okay.
Nobody, and then bottom line, nobody should be, if you put a depends on somebody because there could be an accident, I mean, that's one thing. But if you're putting a depends on somebody because you're not helping them go to the bathroom as often as they need to, that's a different story. And that, I mean, that's not best care, bottom line. And in addition to that, letting somebody then sit in a wet depends, we know what causes that. So, right, frequent urination, get somebody the care that they need, get them to the bathroom so they can empty their bladder. And then also change their depends if there are accidents, because sitting in high pH urine that is full of bacteria, that is wet, perfect combination for wounds. I think that's why you're speaking to something that is really, really major here, which is why we're even talking about this, because it's a problem. And there is a best practice. There is a way that we should be doing things. And that's what we're talking about now. So
I also, sorry, there's a couple more things happening in the chat. I think one question, as far as how do you deal with facilities, I think this is more on like the social work kind of advocacy side than the medical side. But if you have someone that's in a facility and you're noticing things that are off of what we now know to be best practice, that's where you can call in like the ombudsman is an agency that works in a long-term care facility, right? Or a patient care advocate. So that's one option for advocacy if you're really seeing this kind of not best practices being given. And then we have another question is, are there any recommendations for urologists who focus on older adults and or people living with SCI, which is an acronym I don't know, but do you, Becca?
No.
Okay, Monique, if you could, spinal cord injury. Thank you.
Oh,
So
sorry.
that's
So
actually,
what's
that's
the
last
question? What's the question about?
The question
spinal
is,
cord
are there
injury?
any recommendations for urologists who focus on older adults and or people living with spinal cord injury?
Well, okay. So I would say that the people that are suffering from a spinal cord injury have similar complications and issues as somebody that has issues related to incontinence from other reasons as well. So the point that I'm making is the etiology, or like the way that it all started, that somebody has urinary issues, it could be different for everybody, but the diagnosis is different, and getting to that diagnosis is different, but treatment and way to take care of these people is overall pretty similar, and that is these best practices. And for spinal cord injuries specifically, those ones I think are different because there are less there some for sometimes there are less treatment options, because sometimes, you know, getting muscle tone back with like muscle like pelvic floor muscle exercises aren't options. So I don't have a good answer for that, with the exception of the options sometimes are less limited, which is unfortunate. Thank you for that question. This is, I think this is going to be the time where I actually ask people to take a break, because then we'll come back in, let's say 5 minutes. Is that okay?
Yeah.
Okay. So let's all come back in 5 minutes, and I'll go on to the rest of the talk, which is going to be a little less specific to like medical jargon and medical details, and we'll talk a little more about community stuff.
Do you want to make it 7 minutes so it's right back at 11? I feel like having people come back at 10:58 is going to get a little squishy.
You're so right. Let's do that.
All right, 11 a.m. everybody.
Okay.
All right, everybody.
All right.
So I don't know if I'm jumping on Caitlin's toes. You do the disembodied voice better than me, Caitlin. She says not at all. Okay. Well, hey everybody, it's 11 a.m. according to my clock. So
All
I
right.
suppose we will get started. Everyone's already muted and videos are off. So I think Becca, you have the floor.
Thank you.
Quick reminder about, I don't think there's probably too many new people, but yes, you will get the slides after this. And if you have any comments, they can go in the chat. You'll hear me, Ashley, interrupting Becca to give comments and feedback. And then if you have questions that you'd like answered, my request would be that you put them in the Q&A section. That way I can keep track of them and whether or not we've answered them before. And then Caitlin has put in the, oh yeah, Caitlin is putting in the chat all the things that I'm saying. So, all right, Becca, go for it.
Okay. Thanks, Ashley.
Oh, wait, I'm sorry. There was, sorry, there was a question in, or a comment in the Q&A section that I wanted to make sure we covered before we kind of move forward. It's kind of speaks to that one comment about what do you do with a facility that has people who are not necessarily dementia, but have continence issues, and need people to physically take them to the bathroom, but they're being diapered instead. And then more feedback on that was taking residents to the restroom also helps with other body systems and movement, specifically, around getting them up and out of a wheelchair. I wanted to see if you had any thoughts about that.
Yeah, that's an important point. I think that one of the things is that can increase the risk of urinary issues like retention retention is just a sedentary lifestyle, really not moving much. Somebody might hold on to their urine longer than they would have otherwise if they would have just been able to get up and go. So, and we know that retention is a risk factor for a lot of other things. So that's one thing. Getting up and moving will reduce the risk of that. And then you have to also just think about getting somebody up and moving reduces the risk of all kinds of things. I mean, physical movement is so important for older people. The more they move, the more older people are. I mean, there's a lot of research out there that says the more sedentary your lifestyle is, the higher risk you are of all sorts of things, not just urinary issues. I'm focusing on that because it's the talk right now, but I mean, cardiovascular disease, etc., so many things. So that's the first thing. And then the other thing is getting up and emptying the bladder can also, you have a lesser risk of like having issues with stool as well, being constipated. It can just there's a lot of good that comes from getting up and moving. So, and then that also there's another whole talk that we could do about issues that you see in residential care facilities. There's data out there that I didn't prepare for this talk, but there's a lot of data out there that shows people in the community, older people over 65 in the community versus people that live in nursing facilities are higher risk of developing UTIs, higher risk of developing all kinds of issues. And so some of the issues that you guys are bringing up are important. It completely backs up the science that's out there. Medicine and these research papers that have been published can't necessarily say what the cause is, but we know there's a correlation of people living in residential facilities and having issues such as these. So we know it's a problem. We know that there's something that's causing this, and we can guess to what exactly it is. It's things like diapering clients instead of getting them up and moving and getting them to the bathroom. And then there's a whole nother talk we could do about best practices and ways that we can get there with advocacy and better funding for rehab, for nursing facilities, and a lot of things. There's a huge issue with turnover with those places, and that comes with lack of funding, that comes with deregulation of these places. So I could go on and on, but.
Absolutely. And one additional point to that, Russ is saying loss of control around anything is very discouraging and depressing, especially, you know, if it is a basic kind of aspect of self-care.
Yeah. Yeah. There's a lot of research out there as well that talks about depression in older people and how people suffer from depression from loss, and this kind of grieving loss that we talk about when we talk about people losing family members, friends. But there's this exact type of loss and grieving that exists when people lose their ability to go to the bathroom on their own, to drive, to cook their own meals, all of these things, this independence that makes us so human. When that's removed, it can be very demoralizing. And we'll talk about that in a couple of slides about just depression, isolation that comes with these issues. So thanks for that. Okay, I'll jump back in here. So next, I'm just going to talk about useful tools, just things that people can think about in the community, things that people can do on their own. So first thing, preventing urinary tract infections or UTIs. Limit alcohol intake. That's dehydrating. Limit caffeine intake. That's dehydrating. If somebody's like a big tea person, there are plenty of teas without caffeine. There's coffee that's decaf. If people really need these things for their routine, you can still do them, but limit the actual caffeine that you're taking in. And then drinking at least 8 glasses of water a day is what we say. Remaining hydrated, even if you're not necessarily thirsty, just making sure that you stay hydrated so that you're not making it so your urine is super concentrated and then sitting inside the bladder for too long. For older people, taking Senna, taking Miralax, over-the-counter stool softeners, and light laxatives can be helpful to take daily. And then keeping a healthy weight. For the same reasons that I was talking about, this muscle weakness to the pelvic floor, the muscles that contract the bladder. Being some of the risk factors also for incontinence and issues related to incontinence is obesity. And that is because with obesity inherently, you have some level of, if there's a sedentary lifestyle, you have some level of muscle weakness related to the core and the pelvic core. So that's a risk factor. So keeping a healthy weight and exercising. And then if somebody does have issues urinating, and if there is a concern that they're not emptying their bladder fully, or they've got issues with urinary tract infections, then for women, taking several minutes to sit on the toilet in a very natural position, relaxed, that can be helpful to help them really get all the urine out. For men, standing in a very natural position. We see this in the hospital all the time. I take consults in the hospital where urology related consults, and I get called by doctors that say, this guy can't pee. We don't know what the problem is. And one of my first questions is, well, is he walking around? And are you having him pee in a urinal, like in the bed? And the answer is almost always yes. So one of the first things I say is, get the person up, move them, walk them to the bathroom, and they're going to be better likely to empty their bladder. And then preventing UTIs, also wearing the cotton underwear, like I said, keeping that area nice and clean and dry, and also for women, wiping from front to back. So
sorry, there's a couple,
this is great.
a couple questions here. I had a question. So one, you talked about stool softeners and light laxatives. Are those dehydrating or no?
Well, they definitely can be. Those are going to be very important to like self-titrate. So you're right. Stool softeners especially actually can be dehydrating. So there is definitely going to be a level of like staying hydrated to stop yourself from getting constipated, but then also if you need something to help you have a bowel movement, then balancing that, working together. So thank you for bringing that up. That's an important point. I would say that stool softeners like Colace is really well known to be dehydrating. Miralax, Senna, less dehydrating. Obviously, if you take too much of it and you're having stools that are like really watery, then your body is losing water. So that's dehydrating inherently.
Mhm.
Okay.
Okay, then we have, awesome. Then we have three questions. So one is kind of looking back slightly before when we were talking more about long-term care residents, a question about higher UTI risk in long-term care. And the question is the higher UTI risk around in long-term care residents due to the fact that this population already has more complicated chronic conditions than adults in the community?
That's a great question. And unfortunately, none of the data that I know of can really call out exactly what the cause is. These studies are all correlative, and meaning they're just kind of connecting the two things. So a really good study will say, look, these are the limitations of the study. We recognize that people that live in facilities often will have higher incidences of like chronic issues. So you kind of have to go into that with that assumption, and then you can kind of make judgments, but nobody's really able to say, at least not the studies that I know about, are saying exactly what the cause is. But you have to take all of it together, because there are also people that are living in the community with a lot of chronic issues, that if there was a really good study that compared people with a lot of chronic issues to people with a lot of chronic issues in communities, a lot of chronic issues in like rehab facilities and long-term care areas, and then the community, and then doing a really nice study to compare it that way. That would be a good way to do it, but I don't know of studies that do exist that have that information.
Okay, awesome. Two more questions, and these seem to be a little more concrete. So I'm assuming this question is intended for people with male genitalia. It says, is it better to squat versus sit when urinating? I actually don't know which kind of body this is intended for, but I suppose, yeah. So is it better to squat versus sit when urinating?
If you this is a really easy one to answer. Sit. Absolutely sit. Relax everything, because if you're working really hard, like even if you're just kind of, even if you're super in shape and like squatting is really easy for you, some people are really working to do that. So you're tightening the muscles in the pelvic floor, whether you know it or not. And if you're not relaxed completely, then it can be harder to really empty everything.
Okay. Last one so far is why cotton underwear and not quick dry? And maybe you could tell me what quick dry underwear is, because I thought that was just cotton underwear. So perhaps two questions in this one.
The reason is cotton. I think quick dry is that like the workout material? I don't entirely know.
Oh, I see.
Maybe, but either of those are fine. I think the point is more like, don't wear things like silk, or there's a lot of material out there, especially for females, that is not drying, and it holds moisture for too long, especially things that are like really tight, because if you wear really tight underwear, there's not a lot of airflow, and it doesn't have the opportunity to dry.
The chat agrees with you. So someone was saying that Catlin is saying that quick dry synthetic, and Russ says yes, no airflow. So looks like okay, it's synthetic underwear, but yeah, okay, there is synthetic underwear with cotton crotch panels. Yeah. Okay.
Yeah, which is fine. That's fine too. But yeah, the point is cotton dries really easily.
All right. That's okay. Cool. Yeah. I'll hand it back to you. That's all we've got in the question in the chat part.
Great. Thank you. Okay. So then I want to talk about powders and the creams and the different over-the-counter things that are available. If you've got a client that is incontinent, then and the issue is the simple fact is they can't get to the bathroom as often as they need to, and they end up sitting in Depends for too long, then they end up with a rash. And this is really not this is not unlike a diaper rash that you see in a baby. So this can develop, and this is the product that I have here on the screen is Destin, which if you have children, maybe you've seen it. I don't, but I do know that that is something that they use for babies and diaper rashes. And the point is that it can be used on older adults as well. And the most important ingredient that exists in these powders, creams, whatever you get over the counter is zinc. Zinc is what helps heal these wounds. And so if you're ever like trying to buy something over the counter, look on the back of the package and look for zinc oxide to be on the list of ingredients. And that's what Destin has. Okay, so the next thing, when I talk about those exercises for the pelvic floor, the muscles that connect to the bladder, I'm talking about things like Kegels. Ladies probably know what this is. Men, maybe you do, maybe you don't. But women, I think, are taught to do this pretty early because if you're a woman of like childbearing age, you've got the risk immediately after having a baby of having issues with incontinence. And the issue is because these pelvic floor muscles are stretched out, they're weakened. And so what we're told to do is Kegels, and a urologist will tell somebody, a man or a woman, to do this for any reason if they've decided that it's related to muscle weakness. So what they'll do is they'll tell you to start to go pee, start to urinate, stop midstream, and then identify what that feels like. Identify the muscles that are involved and how much work that takes to stop in the middle of you urinating. And then identify those muscles, then you can finish urinating, and then do that same feeling over and over and over again, like every few hours in a day. And then you're kind of practicing the best you can at strengthening those muscles. We actually, in the hospital, we take out people's prostates for prostate cancer, and they have to cut all the muscles around, not all, but they have to cut a bunch of those muscles. And then guys suffer from, after they've had their prostates taken out from prostate cancer, they suffer from incontinence. And we tell them to do these exact exercises as well.
Awesome. One question.
This is a great slide. I knew that this was going to be kind of the meat of it.
Generating thoughts. So this is specifically about incontinence products. So Kate asks, I've seen newer incontinence products that absorb liquid and look like real underwear instead of a diaper. I think it's similar to the underwear that's been developed to use during your period instead of using pads or tampons. Oh, that's like the Thinks brand, those like absorbent things. So is that recommended? Like the underwear kind of style versus Depends style? I hope I'm doing justice to your question, Kate.
I don't know anything about those, so I can't speak too much to it, but I can say this. Being dry is better than being wet. Having something absorbent is better than having something that is not absorbent. So if this product does that, then that's excellent. I would say that what the issue, it shouldn't be replaced with though, like it shouldn't be that you think, okay, well, it's quick drying and I just don't have to change them then, because the issue still sits with, the issue is still that you're sitting with the bacteria, and that's still not great. So still change them as often as you would a Depends.
Yeah, Kate brings up a good point that it's a pride thing for so many older adults. So like maybe the barrier to getting someone to use an incontinence product might be slightly less if it looked more like underwear. Yeah.
Yeah, I completely agree with that.
Whoa, okay. I suppose this is feedback. Yeah, I mentioned that one brand, not because I know anything particularly about, because it's the only one that I could think of, but audience member says attorneys working with class action are investigating whether class action lawsuits can be filed following reports that Thinks underwear contains toxic chemicals. So, maybe not that one. I
Somebody
don't think
knows
they're an
more.
incontinence product, but so, okay, but otherwise it looks like your feedback is dry is better than wet, absorbent's better than non-absorbent, changing people frequently is better. And then maybe, I suppose, is it better for people to just have cotton underwear and be changing more frequently if there's dribbles, or should there be an incontinence product, or is that just like dependent on the situation?
I would say that you should still have an incontinence product if you're
Okay.
if the dry underwear is shouldn't be replaced for if somebody actually has issues with dribbling or whatever, they should still have a something absorbent. So I mean, even if I actually have said this to a lot of my patients, which is that like, and maybe some guys would be like prideful about this and maybe not, I don't really know, but it's something that I say, instead of wanting to put on that whole diaper, I mean, women's products, like for female, not incontinence, but like female menstrual cycles and stuff like that, they're perfect. You can put them on a regular pair of underwear and then take them off. And then you can just pull down your underwear and just like peel it off, throw it away, put a new one on. And you're not like having to change your entire situation every time. That's assuming the incontinence is mild and it's just little dribbles. Because if you're really just like having full accidents, that's not going to be enough.
Further feedback. Sorry, it's a chatty group, which is good.
Yeah.
Let's see. So we have some feedback that changing of underwear is a real challenge for those with mobility challenges, such as like lower body fractures. So I think that's speaking to the kind of middle ground of if you've got like light issues, you can have regular underwear and have just like a pad that can be kind of removed, like a panty liner or a menstrual pad or something.
Yeah.
Like an incontinence pad. Okay.
Exactly.
All right.
Yeah.
So for now, there's nothing else happening in the chat, but
cool.
I'll pop up if something else does.
Sounds great. Okay. The next thing I want to talk about is scheduled voiding. This one is really important for anybody because if somebody has issues with urinary tract infections, emptying the bladder, as we know, is the best defense mechanism. So even if you don't feel like you have to urinate, still do it. But this is really major for people with dementia, people that are forgetful. And this is something that we have to tell people to do all the time. Remind your loved one with dementia or delirium or what have you to please go to the bathroom, bring them to the bathroom, even if they don't have to go. And then the other thing I wanted to talk about was structured drink rounds. This is the exact same thing, but with drinking water, especially people that have issues with memory, cognition. They need to be reminded to drink water because their brain is not processing that this feeling of having to urinate or this feeling of being thirsty. Sometimes, this doesn't go for everybody, but sometimes it's not processing that information that means they need to get up, go to the bathroom, or get up and go get a drink of water. So we have to remind some of these people to do that. Okay. Okay. Next, I'm talking about frequently used medications. So I talked about a lot of stuff. There are 3 medications here, though, that I just said that I would talk about some medications, and I want to talk about these 3 specifically because number 1, Diapering is a common medication that's associated with taking when people have incontinence. So Diapering is this class of medications called anticholinergics. That's really fancy, but what I'll say is think of any medication that that will dry things up. So people take Mucinex if they've got like a runny nose, that's an anticholinergic. People take Benadryl if they've got runny nose or like watery eyes, that's an anticholinergic. This kind of medication is really actually super common, but it's not a great medication for older people. And Diapering was used for a long time for people that have incontinence issues, and it still is. It's like one of the number 1 medications that's used for incontinence. But the issue is that in 2015, there was a landmark study. There was a really big deal in medicine that showed that it followed people over the age of 65 that had been taking Ditropan for longer than between like 3 and 5 years, or 3 and 10 years, sorry, it said that there was a big association and risk of developing dementia. Again, none of these studies can say this medication caused this dementia, but what they can say is taking this medication and being over 65 is strongly associated with dementia. So it's, I mean, this is just kind of how it is in medicine. We never have a perfect answer, but if you design the study in such a way that can give you a really compelling argument to say that this is risky, then we have to listen to it. And this was one of them. It was a really major study. So what I mean, basically, I think the FDA has like a warning now on this medication for people over 65. But the thing is, people over 65 are the ones that are suffering from urinary incontinence so often. So we're kind of like stuck between a rock and a hard place in this way. But that's really kind of like new information that is really fresh, and you'll still see a lot of people on Ditropan. And for some people, it's, you know, they've been on the medication for a long time, and it really helps their lifestyle and it helps their life. And you have to kind of know that too. And it doesn't cause dementia for everybody. We don't know that for sure. So so in any case, that's just kind of a study to be aware of. All right, next, Flomax. Flomax is a medication that was originally designed as a blood pressure medication. And there are these receptors, they're called androgenic receptors that exist in the heart, and they also exist in the prostate. So they designed this medication to dilate the vessels and through those receptors, and they found when they gave this to people to lower their blood pressure that they ended up with better urinary tract issues as well, because their prostates were relaxed and much smaller. So as you can imagine, though, there's a risk of lower blood pressure and like hypotension. If you give this to somebody that already has low blood pressure, then it's a risk. So it's just something to keep in mind, but it's a really great medication for guys with prostates.
I've got questions. Sorry.
Mm-hmm.
Couple things. One, there was just a general feedback, doesn't look like a question. Someone was saying that marijuana has some anticholinergic effects and antihistamine effects. Wanted to see if you had anything on that. And then the question is, what if a patient already has dementia? Then would there be more harm or would there be a risk of worsening the dementia if they had a new addition of ditropin or ditropan? I don't know how to say it.
Yeah, no, that's a really good point. And actually anticholinergics, this class of medication, for anybody with dementia, you have to be careful giving it to them, because it can exacerbate it in a temporary way and give them like delirium or like acute confusion. So to answer the question, yeah, it definitely has to be thought about carefully before giving to people with confusion. In the hospital, I work in the hospital with people with urinary issues all the time, and we really try not to give this medication to older people. We really just try to avoid it completely, but we give it to young people a lot. And you can give it to them for a little bit of time, and then the hope is that they're not on it for their whole lives. But
all right, that answers the question. Erin says thank you.
Great. All right, and then the last one I wanted to talk about was mirabegron. This is a fancy new medication that is new, like in the past, I really don't know, but I think like 5 years or so. This one has the benefits of ditropan with incontinence, and it is super expensive. So even if you have insurance, sometimes it can be, I looked it up, $500 for 30 pills. So obviously it's not an option for a lot of people. Maybe one day it will be. So we're making changes, and medicine is making changes, trying to adjust with the like loss of ditropan. So they have this new drug, mirabegron, but it's expensive. So it's just really not widely used at all. All right, the greater impact. This is an important slide. Go
Sorry,
ahead.
question,
Mhm.
medication
Mhm.
question. So question is about what about Prozcar, Prozcar, which sometimes is given when Flomax is not enough.
Hold on, let me look that one up. What's it called?
Prozcar.
Oh, yeah. That one, that one's a different type of it also attaches to receptors in the prostate specifically. And that one is also, it's a second line medication from Flomax. So that's why I didn't add it in the in this talk, but you're right. That means if somebody's on that, that basically means that Flomax wasn't enough.
Okay, and then one other question about medications is how exactly, and this might not be relevant, how does mirabegron act?
That's a good question. I actually don't know. I know that there's a risk of high blood pressure with mirabegron, so it does work in the vascular system in some capacity, and I mean, most all medications bind to a certain receptor. It's about the pharmacy or pharmacology people figuring out where these receptors exist and how to take advantage of them. So whatever receptor it does attach to, it must exist in the vascular system as well because it causes high blood pressure. So sorry, I don't have a great answer.
I mean, I don't think you're responsible for answering every single question about how every single medication works. I'd say if you have a question about how a medication works, that's always a good thing to follow up with the prescriber or the pharmacist. There is another question. Says, is there a situation where a catheter is necessary in the outpatient setting for urologic issues? So if someone really won't be able to manage this on their own at home, how could a case manager in the community advocate for other treatment or options?
Yeah, we send people out with catheters all the time because sometimes they're a lot of times temporizing. Like if somebody, they shouldn't know, some people end up with catheters forever, but it's not a good answer. If they end up with a catheter forever, then hopefully at some point it's exchanged to be a suprapubic tube, which is a catheter that does not sit through like the meatus or like the natural opening hole. It actually sits like below the belly button and goes straight into the bladder. And I could talk probably for like 8 hours about the different reasons that people end up with the different types of catheters and why. But to answer the question, sometimes going home with a catheter and having a catheter is absolutely necessary. And most commonly, it's because somebody has some acute event and it caused urinary retention. And mostly it's in men. And usually it's related to the prostate, but not always. And one of the things that we do is we put catheters in and we let the prostate cool down from any sort of like traumatic issue that happened with it in the hospital. And I'm just assuming that maybe they went from not having a catheter to having a catheter. And usually there's some precipitating event that occurred that ended them up with a catheter. But they're not a good long-term solution. What is better is self-catheterizations.
So I guess, sorry, this social worker in me is like, well, okay, good. So if there's an acute event, they get a catheter in the hospital, and if we in the community are like, this person is not going to be able to manage caring for this successfully outside of a medical environment, like what are the options? Is having a catheter something that can be managed in a skilled nursing facility, or like, is this something like, yeah, I guess that's my question is like,
yeah, I've discharged people from the hospital because they couldn't take care of their catheters to a rehab facility. So
okay.
Yeah, it's
just trying to think of advocacy that can be done, if someone is in the inpatient and we imagine they're going to step down to a home environment that doesn't have a significant amount of support, where can we kind of advocate for, and how long? I guess it's hard to really say how long someone would have a catheter after they get discharged from a hospital.
it's usually, I mean, if they get discharged from the hospital and they have a new catheter, it's usually not for more than a couple weeks. But but that's a very specific kind of thing. Sometimes people end up with catheters for years, but bottom line is like there's something going on there and a urologist needs to be following.
Okay. Follow-up question, would home health be covered for support with managing this?
Yeah.
This is obviously an insurance question and not necessarily like a medical question, but I think it's a valid one, right? Like if someone's going to discharge from the hospital and, you know, even with in-home support on board, you know, unless there's enhanced kind of service for it to be a kind of paramedical thing, would home health, like outreach, would that be something that
Yes, it gets covered.
Okay.
I for most of the time we
Okay.
can cover it.
Okay, and then to back this up, so, and this is not a question, just feedback says, I've had clients in independent living with a catheter and they go to their urologist every 6 weeks for it to be changed and they've had it for years. So this is a successful intervention. Awesome.
Good. Yeah, and sometimes that's all that people can do, and like that's all they want to do, because sometimes it's like some major surgery that's the only answer or what have you, but yeah, exchanging catheters every 6 weeks is something that we do, and sometimes it's the best option.
All right, all quiet on this side, go for it.
Okay, sounds good. Greater impact. I'm going to try to go quickly. Well, let's see, how many slides do I have? Only a couple. All right, this is probably one of the bigger, more important slides in the whole talk. Incontinence is associated with emotional loneliness. This is kind of a really, as you guys know, a well-known phenomenon. If somebody is incontinent, they want to hide it. They don't want to tell other people about it. It's a source of shame for so many people. So as a result, they are then hiding it, and then they become isolated, and then they become lonely, and then they become depressed. It's a cycle that occurs with incontinence. And then if you think about somebody having incontinence and needing to get up from their wheelchair or with their walker, walk through their home to try to get to the bathroom or change their Depends frequently, then once they get there, assuming they get to the bathroom, then they're pulling down their briefs, their Depends, what have you, and sitting down to a lot of times a low toilet. There's a high risk of falls there, especially if they're getting up frequently and often and they've got functional disabilities, then this is a high risk of falls. And anybody that knows that of older people that have fallen, you know that there's a high risk of fractures associated with older people falling. So there's a lot of data out there that shows that incontinence, again, this is not cause, this is just correlation, but incontinence is associated with higher risk of falls. And then if you go one step forward, if somebody is falling and breaking something, especially a hip in older people, but anything, there's a higher risk of morbidity and mortality, long-term bad results from fractures for older people. There was a study in 2019 that it was done in China, and there were 800 people enrolled in this study, and it showed that the risk of falling and developing a fracture was 26% higher if there was an older person over the age of 65 that was incontinent versus somebody that was not incontinent and over the age of 65. So basically what I want to get to is people that are incontinent or people that have fallen, they have there's a correlation, and it's related to sometimes incontinence. Again, not always, but this is a correlation and something that's well studied. Okay, next is when this becomes an emergency. When any of these issues that we've talked about becomes an emergency where you need to really like get a hold of the doctor that day, call 911 or any other intervention that we'll talk about. But one thing is, if you know somebody that has a urinary tract infection and they start developing back pain, especially if it's back pain on one side of the back, that tells you that there might be an infection going up to the kidney. And once the kidney gets infected, that's very serious. So this might be a reason to, if they've got fevers, if they've got back pain and they have a UTI and you know that they have a UTI and they're on antibiotics, this might be a reason to call 911 or like go to an emergency room. And then fevers with a UTI. This is something, if you know somebody has a UTI and they're being treated for a UTI, but they're still having fevers, you have to start thinking this antibiotic is not covering whatever's growing in the bladder. So this is a reason to like call the doctor. But if somebody becomes very confused, they've got cognitive changes and delirium, this is like acute confusion, even in the setting of somebody that's normally confused, if they're like wildly more confused than normal, and you know that there might be some type of infection or they're at high risk of infection, or if you know that they already have an infection, they're being treated for it, that's a reason to get a hold of somebody, call the doctor, or if somebody really starts to become really unsafe in some way, then you call 911 as well. And then fainting or passing out, losing consciousness, that means you might be becoming septic and that you need to call 911 if somebody has an infection and they're being treated and some of these things are happening. All right, not being able to urinate for over 8 hours. There's a story I wanted to tell. I was like practicing this last night actually, and I remembered as I was looking at this slide that said unable to void for 8 hours. I don't know if anybody here heard about this story, and maybe just like raise your hand or something if you have. But in 2019, there was this story that went viral because there was this doctor that poked a hole in someone's bladder on an airplane because they went into urinary retention for like some really long flight that was like over some ocean. They could not land or like get this person medical help, but this person had like this person like passed out. They had a super high heart rate, they were sweating, and they had all these changes. They became confused before they passed out, and it was very clear that this person had not peed and he could not pee, and it became a medical emergency. So this doctor that was on the plane poked a hole in the person's bladder, like through their, that suprapubic area that I was talking about, like below the belly button. This is gross, maybe, but it also saved this person's life. They sucked the urine out of that person's bladder and they saved this guy's life. And so the doctor was interviewed afterwards, and he said that he had a high suspicion when his family told him that the patient or the person that had passed out, the family members told the doctor that he had an enlarged prostate. So that's kind of like a salacious, like, I don't know, kind of crazy story to tell about what could happen if somebody goes into urinary retention.
That was a good one.
Okay. So this is actually, I think, one of the last slides in the talk, and I just wanted to go back over the case study. And I won't read it again to save everyone that, but I just kind of, instead of making everyone answer those questions again about your concerns, your possible interventions, I'm changing this in real time because the answers were just all so good last time. I think that basically what I wanted to get from this slide was that we all learned something here today, that people, if they're not peeing, then they're at risk of developing an infection. And if they reduce their water intake, they're at risk of becoming dehydrated. That comes with a lot of other issues, but infection is one of them. They're at risk of developing bladder stones, as you know. They're at risk of developing like contact dermatitis, the skin rashes, the wounds. This guy was at risk of developing all of these things, and we learned about them in this talk, but we also, a lot of people already knew. And then things that you can do for James is reminding him to drink water, structure drinking rounds. If James is a family member, bring him a glass of water every couple hours, no matter what. And then you can also try to set him up with some resources in the community for Depends and incontinence supplies. My next slide talks about some of those resources that exist in the community. But one of them is like diaper banks, food banks. These places actually can provide incontinence supplies if somebody's insurance does not cover it. And but a lot of insurance companies might. So it'll be a matter of kind of like figuring out what is specific to that person, but know that there are resources out there. And then requesting a doctor's appointment for medical management of his pain was also something that I had on there too.
There's a question.
Yes.
Possible, this is, I guess, maybe falls under the possible interventions. This is a question about our natural remedies to help prevent UTIs, like cranberry pills or cranberry juice or probiotics effective.
Yeah, that's a great question. Thanks for bringing that up. I'm surprised I didn't bring that up actually, because yeah, there are studies out there that say cranberry juice makes the urine even more acidic than it already is, and it can make it so that bacteria can't grow as well. Sometimes if somebody doesn't have enough good bacteria that exists in their bodily flora, that giving probiotics, that good bacteria, might help. And that is especially for women, like with the estrogen issue that I was talking about. So studies do show that those things can help. They're not always that effective, but for certain people, the risk of adding that to their medication list is really low. A lot of them have like no side effects and there's no risk of it. And a lot of those natural things like cranberry juice and probiotics, but that's not to say that all like herbal supplements and like natural supplements don't come without side effects and risks, because that's absolutely not true. But those ones specifically are pretty low risk.
Awesome. Thanks.
Thank you. Okay, and then these are just, I wanted to give people an opportunity to ask questions here. I also wanted to talk about a couple things. Number one, the CDC has, if you type in incontinence or like benign prostatic hyperplasia or something into CDC's website, has really awesome patient education resources and like really easy to read things. So check out CDC's website. And then the National Diaper Bank was created originally for like babies and like new moms that didn't have diapers for their babies, but they also supply incontinence supplies for older adults, and they exist all over the United States. And then the Simon Foundation for Continence is a group that can help supply incontinence supplies. And also importantly, this is a support group that exists nationally that has like little groups in different areas that get together, and they also have like a discussion board online. People can talk about their any kind of like emotional support that they might need that's related to their incontinence, shame, or depression, or other issues they might be suffering from. And that is everything I have. So I will wrap it up and let you guys ask questions if you want.
Awesome. There is. So one person, Annie, says, I need to prepare for another meeting, but want to say thank you. Appreciate the presentation and discussion. Ooh, hashtag gratitude. Nice. And then Russ says, hot sitz baths are great, but then there's a problem of getting in and out of the tub. So I suppose since I'm already talking, I will take a second to direct everybody's attention right now to the chat. And Heidi is saying this is extraordinary information and so useful. Yay.
Yay.
Okay, so I'm directing everyone's attention to the chat because I, right now, have put a link to our SurveyMonkey evaluation. So the survey is live right now. It shouldn't take you more than a couple minutes to go through the survey and provide us feedback about this training. And I think there's an option for you to tell us about more trainings that you would like. So yeah.
Thank you for
Questions,
that, Ashley.
comments, concerns? Becca, fantastic work. And yeah, so let's see, Kate says, thank you so much. This was so beneficial. So yeah, if anyone has any questions for our presenter or any comments, now is